Good morning. This is one of the core lecture of Advanced Life Support course, Airway Management. We hope at the end of the lecture, participants should be able to know the fundamentals in airway management, describe the airway hierarchy, be able to use the airway devices, understand the complication of each devices, and know the update in airway management during this COVID-19 pandemic. Airway management starts very early in every resuscitation process. We don't wait until patient have cardiac arrest, then only you walk in. Because the main aim of airway management is to maintain the adequate oxygenation and sufficient elimination of carbon dioxide. For example, oxygen concentration in the air is 21%. When any of the victim come in with desaturation or complaint of shortness of breath, all the rescuers should be able to use the knowledge to give oxygen to the patient. And airway management choices depends on the patient's factor, the phases of resuscitation, and competency of each rescuer on the different gadgets and tools. First issue in airway management, oxygen during CPR. I'm sure everybody understands too much oxygen is not good. But during CPR, when there's very minimal flow to the cell, one should use maximum feasible inspired oxygen concentration during CPR. However, after return of spontaneous circulation, you should titrate the inspired oxygen concentration to achieve SpO2 in the range of 94 to 98% because too much oxygen post-cardiac arrest period is not good. What is so-called airway hierarchy? When you go to give oxygen to the patient, you should know what are the oxygen delivering devices. For example, nasal prong, simple face mask, venturi mask, and high flow mask. But when you need to give manual assist ventilation, those non-invasive airway devices such as oropharyngeal airway, nasopharyngeal airway, pocket mask, and back valve mask, you should know. What is so-called invasive or advanced airway devices? Examples are laryngeal mask airway or endotracheal tube. I like to ask these questions during ACLS course because these are the most basic principle of airway management during resuscitation. Question number 1. Is it necessary to intubate patient during CPR? Of course, the answer is not necessary. So question number 2, in which type of situation the rescuer can choose not to intubate patient during CPR? The answer is condition 1 plus condition 2. Means number 1, the rescuer does not know how to intubate, so you cannot waste time because you understand that chest compression is a very important merit of successful resuscitation technique. And the second thing is you should be able to provide adequate mask ventilation to the patient. What do you mean by adequate mask ventilation? Which means to provide the tidal volume at least 5 to 6 ml per kilo to the patient. But how do you know your mask ventilation can achieve that target inspired volume? The answer is whenever there is visible chest rise. This go for tidal volume of 5 to 6 ml per kilo to the patient. Now, question number 3. For the same case, when should the rescuer now got no choice to intubate the patient? The answer is when there is return of spontaneous circulation because you got to do post-cardiac arrest care for this patient. Now we talk about oxygen delivering devices. This is important because for each type of devices, we need to know how much oxygen we give to the patient, which correlates to how many % of oxygen concentration we give to the patient, because that is to ease us to do the interpretation on the ABG. Generally, there is a correlation between FiO2 and PaO2, and the correlation is about 4 to 5 times For example, if you give high flow mask non-rebreathing type 10 liter per minute to the patient, if this patient has no lung problem, you should get at least 500 millimeter mercury of PO2 in this patient. So first one, we look at the nasal cannula. This is the simplest airway delivering devices in which normally we use 1 to 6 liter per minute of oxygen. And for the first liter oxygen through the nasal prong, we goes about 24% oxygen to the patient, and every 1 liter add on to the nasal prong, we add 4%, in which like 2 liter per minute is 28%, 3 liter is 32%, and so on. Another one is simple face mask. Simple face mask, normally we use 6 to 10 liter oxygen to the patient, which goes for 35 to 60% FiO2 to the patient. Venturi mask. This is a little bit specific airway delivery devices in which normally COPD patients require this type of mask because we need to give desired concentration of oxygen to the patient. And the last one is high flow mask. There are 2 types of this type of mask, rebreathing type or non-rebreathing type. If we use non-rebreathing type, in which we will show you at the airway station, which involve 3 one-way valves. If you give 10 liter per minute oxygen to this patient via this type of mask, we can give near 100% oxygen to the patient. There are 2 methods to open airway, head-tail chin lift or jaw thrust. Jaw thrust is used when people have suspected cervical injury. Again, this will be shown in the airway station. There's oropharyngeal airway and nasopharyngeal airway. It's used to prevent the tongue from falling backwards when the victim actually unconscious. Oropharyngeal airway is important to know the measurement because too short of the oropharyngeal airway used may defeat the purpose and too long may occlude the airway. So how to measure oropharyngeal airway? It's from the angle of the mouth to the angle of the jaw or earlobe. There's another measurement is actually from the mid-incisor to angle of mandible. The next one here is nasopharyngeal airway. Nasopharyngeal airway measurement is from the tip of the nose to the triggers of the ear. Of course, it looks smaller, softer, and better tolerable. But nasopharyngeal airway, there's one contraindication when the patient has ENT bleeding or facial injury, then you don't put in this nasopharyngeal airway. When we want to talk about manual assist ventilation, there are 2 gadgets that you have to understand. One is a pocket mask. Why is it called pocket mask? Because the mask can be folded and keep inside the pocket. And the special thing about pocket mask is there is actually a one-way valve here, so it's safe for the rescuer. This is back valve mask. The important thing about back valve mask is there are a lot of one-way flow here. So therefore, back valve mask can never be used for the patient with spontaneous breathing. Back valve mask should be used to provide intermittent positive pressure ventilation. There's a way to hold back valve mask. This is one-hand technique and this is two-hand technique. One-hand technique is also called EC clamp technique. Two-hand technique is important now, especially in this COVID-19 pandemic, because if you got to give mask ventilation to the patient, it's advisable to use two-hand technique because to have a proper seal and to prevent the aerosol being disseminated to other people. This is laryngeal mask. Laryngeal mask airway is a type of supraglottic airway device designed by Dr. Brain in 1982. It consists of a cylindrical tube, elliptical cup, and inflatable pilot balloon. It's very easily learned and it's very promising ventilation. But the only problem about laryngeal mask is it can never prevent aspiration. Therefore, manufacturer has actually come up to better way of doing LMA is LMA with the drain tube lumen in order to cut down the risk of aspiration. But to remind everybody, it is not a gadget to prevent aspiration. One is Supreme LMA and one is Procel LMA. Supreme LMA is actually a disposable type, and Procel LMA is reusable. Before we use LMA, you got to choose the appropriate size. And the size actually recommended guideline is actually based on the patient's body weight. We have size 1 to size 5, and for adult use, size 3, 4, 5 are commonly recommended. When the LMA is actually placed in situ, it should actually seal the airway and has a promising ventilation. What are the complications of the LMA? It can actually cause sore throat, can cause dysphagia, dryness, can cause tongue cyanosis, and even vocal cord paralysis. But of course, it's less than endotracheal intubation. Now we talk about endotracheal intubation. This is important because now this endotracheal intubation is limited to only skilled personnel, because we don't want you to tube 10 times and has no time to do chest compression. Intubation during CPR should not exceed 5 seconds. And this is scary because I suppose it's only anesthetists can do that. But why is the answer of 5 seconds come in? Because that apply for the interruption of chest compression, because chest compression is a very important factor for successful CPR. The indication for endotracheal intubation will include cardiopulmonary arrest, respiratory failure, airway protection, cerebral protection, those critically ill patient, and when you got to do post-cardiac arrest care. In the emergency situation, ET tube size used for adult male should be size 8 and one size smaller is 7.5. For female is 7.5 and one size smaller 7. Anchoring at the mouth angle for the male patient, if you use size 8 tube, is level 20 to 22, and for female is 18 to 20. For example, if let's say a male patient, the ET tube put out to level 18, 90% of these cases, the ET tube is already, the cuff is actually in the throat. If you receive a patient ET tube anchor at level 24, most of the time, this ET tube has gone into right main bronchus. So what are the complications of endotracheal intubation? If it takes too long, it can cause hypoxia. There are a lot of trauma can happen, including all the soft tissue injury or tooth extraction. You can induce vomiting and cause aspiration to the patient. If intubation is electively done for those alive patient, it may actually cause hemodynamic instability. BP can crash, BP can shoot up, or arrhythmia. Confirmation or advanced airway placement, of course, clinically by looking at the color, visible chest rise, vapor in the endotracheal tube, 5 points auscultation, and the definite thing is by looking at the capnography. But once advanced airway is inserted, there would not be cyclical CPR anymore. The compressor will do at least 10 to 100 to 120 per minute, and those taking care of ventilation will back 10 times per minute. What happened in this COVID-19 pandemic era? Advanced airway insertion is an aerosol generating procedure. So all the rescuers need to don full PPE. And we should restrict the number of healthcare workers in the resuscitation scene. So no more 10 or 15 people during the resuscitation. If CPR going on, we even allow passive oxygenation. Means that if the patient is on a face mask, we will cover the face mask with the surgical mask on the patient and allow passive oxygenation. Avoid that mask if possible. In fact, if you got no choice, then you can put in the LMA. But early intubation is required. We use a cuff ET tube with a viral filter to minimize the aerosol generation. Airway intervention should be done by the most experienced operator. And this is something new. Pause chest compression for intubation. Consider video laryngoscope if possible. An ET tube must be cuffed properly and adequately and secure properly before the IPPV. Clamp the ET tube prior to circuit disconnection or when connecting to the ventilator. Use the inline closed ET tube suction devices. Dispose all the equipment used for the airway safely, and equipment used should be placed in the double sealed bag, and do not leave even the yonker sucker under the patient's pillow, because this can put contamination and get everybody at risk of COVID-19 infection. With that, thank you so much.